complete both cycles, both sessions of the cycle, have the feedback, and then we will be repeating this cycle again in the fall. So again, you should be registered for January 26th, as well as a session for February 2nd, which is the second part of this webinar series. Okay. So I am your moderator. I'm Ingrid Floyd. I'm the executive director of Iris House, which is located in Harlem in New York. We have offices in East and Central Harlem as well as in Central New Jersey. Our organization was founded focused on women, families, and communities who are infected and affected by HIV and AIDS. We do a lot of work in the community as well as nationally around advocacy for women, and a lot of services directly for women who are living with HIV, as well as a lot of other populations. I'm the secretary of the board of the National Women and AIDS Collective, and very excited to be a part of the capacity building co-chair for the National Women and AIDS Collective, which is the body that has helped to organize and put together today's webinar. So our webinar host, again, the National Women and AIDS Collective. Our mission is to advocate and build the capacity of women-led and serving organizations and programs that work in partnership with women impacted by HIV/AIDS in order to improve their overall health and quality of life. The National Women and AIDS Collective is a membership organization, and at the end of the webinar, I'll be telling you more about the National Women and AIDS Collective and how you can get involved. This webinar series, which is entitled PrEP4Life, is a two-part webinar series that we put together to increase awareness of pre-exposure prophylaxis, known as PrEP, as well as provide educational information for high-risk heterosexual women, transgender women, young MSMs, heterosexual serodiscordant couples, medical and social service providers. And we know that we have a lot of people who have registered for today's webinar that represent all of these different populations and who are consumers as well as providers. So again, this webinar session and series has been tailored with all of you in mind. To go over some housekeeping, currently everyone is on mute except for our panelists. If you need to ask a question, you can raise your hand, and if you notice here, there's a little button that you can click to raise your hand. You can also put your questions in the question box, and we will see your questions there. As we go along today, the moderator, myself, I will be able to read out questions that have been submitted. At the end of the session, we will give you the opportunity, if you raise your hand, to have you ask questions during that time. So throughout the webinar, you can just click the questions, put your questions in the questions box. At the end, you will be allowed to raise your hand, and I will unmute your line so that you can ask questions. So our first polling question, is this your first time attending a National Women and AIDS Collective hosted webinar? So we're going to start our poll. So if you could just vote, the poll should have popped up. I see a few more people are voting. All right, I'm going to close our poll. So our poll results show that 80% of our group, of those people who are on today's webinar, 80% attended our last National Women and AIDS Collective webinar series that we did, and we're very delighted to hear that. And 16% did not attend the last webinar. 4% are not sure if they attended or not. So at least majority of the people here have experienced a National Women and AIDS Collective webinar, which means that you got something from it because you came back. So we really do appreciate that. So today's session is entitled The Facts from the Myths. We really want to sit and talk a little about, PrEP and some of the facts about PrEP, and then try to dispel some of the myths about PrEP. And we have a really great group of presenters for today's session. I will introduce each of them separately as they present, but just to let you know who's on our lineup, we have Dr. Dezon Dixon, who's the Executive Director of Sister Love. We have Ms. Ophelia Barrios from Iris House, Senior Director of Community Health Initiatives, and Ms. Prue Mendiola, who's Project Evaluator Research Assistant for Friends Community Center. So you will have an opportunity to hear from each of them. To kick off today's session, we have Ms. Dezon Dixon Diallo. Many of you know Dezon. Dr. Dixon Diallo is a recognized visionary and advocate in the struggle for women's human rights and reproductive justice and the fight against HIV/AIDS on behalf of women living with HIV and those at risk for HIV and STIs. Dr. Diallo is founder and president of Sister Love Incorporated, established in 1989. The first women's HIV/AIDS organization and reproductive justice organization in the southeastern United States. She's a proud member of In Our Own Voice, the National Black Women's Reproductive Justice Agenda, where she advocates for sexual and reproductive justice in public health and prevention policies and programs. For 18 years, she served as adjunct faculty in the Women's Health at Morehouse School of Medicine's Master of Public Health program in Atlanta. She's a member of the board of directors of the National Women's Health Network and is founding member of the 30 for 30 campaign for women in the National HIV/AIDS Strategy. As well, she holds a master's degree in public health from the University of Alabama and a bachelor's degree from Spelman College. In 2012, Dr. Diallo had the distinct honor to receive an honorary doctorate of humane letters from her alma mater, Spelman College. So without further ado, I want to start showing and change over to our first presenter.
So, just to be clear, am I visible, Ingrid?
Yes, I believe so, but let me just do one check to be sure. Okay, try it again, Dezon.
Okay, and I'm just going to make sure that I have show my screen selected, and you should be able to see my cover slide.
We do.
Great. Well, thank you so much, Ingrid. This is awesome to be with you and everyone today. Thanks to Iris House, Christie's Place, and the National Women in AIDS Collective for not only just putting on this webinar, but doing the amazing capacity building work that you all have been doing for a number of years. And welcome to everyone. Compliments of the new year to everyone who has joined us for the call today. My job is to take us through a basic PrEP 101, if you will, and to tailor it a bit on how we might talk about PrEP or pre-exposure prophylaxis for women in the United States. It is on the agenda for us today. We'll talk about what is the U.S. Women in PrEP Working Group, which is the group that has sponsored this particular presentation that you're hearing today. And then we'll go into the specifics around PrEP. What is PrEP? Why do we need it? How does it work? Talking a little bit about some of the side effects based on what's been experienced both in trial and in the lived experiences of women who've used PrEP. Who's using it, and what does this mean for women and girls? Now, the U.S. Women in PrEP Working Group is a nationwide network of advocates, researchers, academics, government, pharmaceutical industry representatives. We came together about almost 4 years ago now as a matter of organizing women's response to the initial application for the use of Truvada as PrEP. We work to ensure that communities and providers, as well as institutions where women access services locally and nationally, are informed about PrEP, and to mobilize the advocacy of women's voices to make sure that we're able to influence the public policy and the funding decisions with regard to the implementation of PrEP and other biomedical prevention options for women in the United States. The U.S. Women in PrEP Working Group is focused in on the advocacy work. We look at our advocacy through several different lenses. One is looking at PrEP and biomedical prevention for women as a sexual and reproductive health and rights part of service delivery, a part of sexual and reproductive health and rights service delivery and advocacy, working in hand with many of the partners that you see represented in the logos there. We believe strongly of women's power to prevent HIV in women's hands, which is why we consistently strive for better, faster, safer, and more effective tools, the research and the tools needed for women to be empowered and have the agency to prevent HIV autonomously. We are engaged in the global advocacy for appropriate research and development for those options for women, and we work in cooperation and collaboration with many domestic and international partners, as I've mentioned. Now, our group is open and consistently growing. We have a leadership team. There are 4 of us, including myself, and Anna Forbes, who is an independent consultant and coordinator for the working group, Manju Chitani and Deirdre Grant, who both are working in the women's prevention, both domestic and global, at AVAC. We host face-to-face meetings of the working group at least once a year. We hold teleconference meetings every quarter, as well as offer webinars once a quarter, and conducting some level of community-based participatory research or partnering with researchers, mostly in the social and behavioral fields, around PrEP implementation and communication. We also, in 2015, established the Transgender Persons Affinity Group, of which we are really a proud host and partner to a growing body of people, of transgender individuals and their allies, to ensure that transgender individuals are included as well as treated as a unique key population in need of these high-impact prevention services. The purpose of our working group is to serve as a national voice representing women, to engage in inquiry, advocacy, and to hold entities responsible for implementing PrEP, namely our federal government and industry partners, to hold them accountable for the inclusion of women, as well as for providing robust education, information, and rollout of PrEP and other high-impact HIV prevention programs, services, and interventions. Another purpose of the working group is to monitor and be sure that women's safety, efficacy, and accessibility is assured in the PrEP research, as well as the rollout of PrEP in the United States at the local levels as well as regionally and nationally. We work to educate and engage communities in the PrEP discourse and in the information dissemination of PrEP. We do this by engaging with many different listservs and by offering some of the webinars, conference presentations, as well as face-to-face meetings and consultations, as has been described already. And again, we mobilize a diversity of women's HIV and health advocates, researchers, policymakers in PrEP and other biomedical prevention options, which is what that BMPO stands for there. And when we say other biomedical prevention options, that could extend from anything from condoms, male and female condoms, all the way to the additional potential biomedical prevention strategies that are in the pipeline. Of course, we include treatment as prevention, HIV testing and counseling, and linkage to care as a part of that, but we're also fighting for the pipeline of prevention options that would speak and serve the autonomy of women to protect themselves, like microbicides or other forms of delivery of pre-exposure prophylaxis or antiretroviral therapies. We'll talk a little bit more about that. And this is just a short list of some of our advocacy partnerships with which the working group is involved, including the AVAC PX Roar Fellows Program. We are included in the PrEPWatch.org website, which is a tremendous resource for up-to-date information on PrEP research and implementation in the United States and around the world. We are participating with the Black Treatment Advocates Network in their Black PrEP Tour, as well as some of these other coalitions and collaboratives that are focused in on either women's HIV research writ large or specifically on prevention research. For example, the HIV Prevention Trials Network's Women at Risk Subcommittee and a small consortium of PrEP projects that have been funded by Gilead Sciences as well. I wanted to just pause to make sure that we're on the same page. When we are talking about women, we're using all-inclusive language, including what's known as cisgender and transgender women. Just to be clear and assume that and to make no assumptions about how people use language in describing women. The way we understand the distinctions and the similarities and how we want to be inclusive around the use of the terminology of women is cisgender women considered the same, which means that as women identified or female identified at birth and now also self-identified. And for transgender, it is folks who are identified at birth differently from how they now self-identify. And so for this conversation, in talking specifically for transgender women, about transgender women and with transgender women, we are clear that those are the distinctions, but reminding ourselves that when we use the term women, that we are using it in an all-inclusive manner. And I would just say, just from an all-inclusive and human rights standpoint here, it is important to ensure that transgender individuals who may have been more female identified at birth and now self-identified in a more masculine sense and have vaginas, uteruses intact, then we also are making sure that these transgender individuals are included in information around PrEP that's inclusive of folks who in the biological sense represent the female identification from birth or at self-identification. So what is pre-exposure prophylaxis? It's basically, in any general conversation of prophylaxis, it's about taking medicine or using a device to prevent something rather than to treat. We think about prophylaxis, as a matter of fact, I say this because I'm old enough, hashtag funkin' at 50, I'm old enough to remember a time when we even call condoms prophylactics. Some younger folks won't remember that, but that even predates calling them rubbers. And so we would think of condoms as prophylactics because they were applied before having sexual intercourse and meant to prevent. But we also think of prophylaxis in the form of birth control, whether it be through pills or injections or implants. We also think of how we take allergy pills or nose spray to prevent congestion when we're exposed to environmental allergens. And of course, there's taking a pill every day to reduce your risk of getting HIV. In the United States, it is still reported that about 1.2 million people are living with HIV. We, while recently learned that these numbers are slightly reduced, it's still roughly about 50,000 new diagnoses of HIV each year. 3 in 4 are in men, while 1 in 4 are in women. And about 1 in 7 people living with HIV doesn't know that he or she has it. And essentially what we also know, which is sort of comparative to the numbers of people that we know who are living with HIV, that's about the same number of people who could benefit mostly from PrEP to prevent HIV transmission. That's about 1.2 million people who would be able to take the most advantage of PrEP in the United States. The unmet needs for HIV prevention tell us that from a 2020 study in the U.S. on condom use, and this is using self-reported techniques, that men reported about 24% of the time reported using a condom in the last sex act, and about 18% of the women said they had used the male condom in the last act of sex, which means that condoms are not used by 3 in 4 men. And there's lots of reasons why. We've all had these conversations if we're health educators, if we've taught people about using condoms, and we've queried with people what some of their challenges are, that some of those reasons are decreased sensation, decreased pleasure, intimacy. Even in some of our own spheres, people still don't know how to use them as correctly, that it diminishes the connection. There are issues around the emotional connection, that the interruption in terms of lust and love and all of those wonderful things that come along with sexual expression as well as sexual pleasure and sexual safety are some of the reasons why people give that they're not using condoms. So in terms of female condoms, we know that while they are available, they're not the greatest option for everyone simply because they're not always available everywhere, and they tend to cost 3 to 4 times more than male condoms and are certainly not as available, readily available, even free of charge as male condoms are, though we are advocating and working hard to eliminate that disparity. So if you imagine thinking about prevention across an entire spectrum or imagining an entire toolkit of prevention, there are opportunities before exposure, for example, through HIV testing and counseling, and in some instances linkage to care for those who are HIV negative and have other health issues or want further access to prevention services through their clinical programs. There is voluntary male medical circumcision, which has been shown, especially in sub-Saharan Africa, to reduce HIV risk by about 70% between men who are circumcised versus men who are not. We also now have pre-exposure prophylaxis, or PrEP. We know treatment as prevention, which is the act of knowing your HIV status, getting engaged in care, staying in care, taking your medications, and getting the virus suppressed or under control. That treatment as prevention is also determined as a wildly successful prevention option, especially for people living with HIV and folks who may be in serodiscordant or serodifferent relationships. And what we identify in the lighter colors are those tools that we have yet to achieve success around, like a preventive vaccine. And in terms of at the actual point of transmission, we know that there are condoms and lubricants available to us. We know now that we can prevent transmission to babies through a pre-exposure or prophylactic, either through now for people who are negative through the use of PrEP, and for women who are living with HIV with the use of the antiretroviral therapies. And of course, cleaning our needles or cleaning injection equipment is another point of transmission option for prevention. And what we look for in the future, of course, is our vaginal and rectal microbicides, as well as other cervical barriers that are in the pipeline or in the research pipeline. After exposure, there is post-exposure prophylaxis, which is a different regimen, from the pre-exposure prophylaxis, but nonetheless, for someone who may be recently exposed to HIV, typically within 72 hours, if they present to a clinical setting, could get a prescription for a regimen of post-exposure prophylaxis antiretrovirals that would reduce, if not eliminate, their risk of becoming HIV infected if they are exposed. And again, treatment as prevention is a form after exposure and after diagnosis with HIV. And of course, we are continuing to look for the successful therapeutic vaccines that are in the pipeline. So in terms of PrEP itself, the drug that's used or has been FDA approved thus far is Truvada, which is the brand name, the tenofovir plus emtricitabine combination, which is also the antiretroviral that has been prescribed to people living with HIV for at least the last 10 years. It is a 1 pill per day, which gives it a relative ease of use. It has few side effects that have been determined to date, and that it stays in the bloodstream a long time are some of the benefits to why Truvada has been proven effective in preventing HIV if exposed. Taking it daily means that it can protect up to 92%, and I'm actually going to have to close my dashboard because I'm missing a part of my little screen. There we go. Taking it daily for now can protect up to about 92% and in many cases even more in terms of the effectiveness of PrEP according to a diversity of studies that have been conducted. And there have been reported side effects, mostly affecting people at the startup time, usually within the first 1 to 2 weeks, including some nausea, vomiting, fatigue, dizziness, mostly engaging around some stomach issues. In a few people, and this is required for anyone who is seeking PrEP prescriptions, a physician will certainly, in addition to running HIV screening, will also do a baseline of blood tests to make sure that there aren't any changes in the kidney function for people who are taking PrEP. There's some indication, especially in some populations, like African Americans, who might be predisposed for renal issues, that we pay close attention to any changes in the kidney function. There's also a slight opportunity or chance for bone mineral density loss, and that all of these are reversed when PrEP use is stopped. So it's very important to understand that PrEP is not the emergency contraception, which has been sometimes misconstrued and miscompared. It is something that you have to take prior to, similar to contraception. And the difference is that there is a time for buildup for PrEP to actually reach protective levels, especially in vaginal or vaginal tissues. So understanding that it's about 20 to 21 days in the vaginal tissue and 7 days in the rectal tissue. And this is important to understand because a lot of the information that we hear in the regular, everyday conversation around PrEP is that you have to be on it for at least a week before it has any protective level in the bloodstream. That's a message primarily for those who only engage in anal intercourse or need the rectal area protected. For folks who also have vaginal intercourse and require vaginal protection, it takes longer for the buildup of PrEP in the system, and that's about a month. That's about 3 weeks. When transgender women choose to take PrEP, there are many questions that come about that may be unique. And not in terms of the cost, because how much will PrEP cost is everyone's question. We'll talk just a little bit about that. But there are some specific questions. For example, will using PrEP cause problems with the hormones I'm taking? And there are other questions. Would they even prescribe PrEP for a woman like me? How much do they even know about how our transgender bodies will react? And there have been studies that have included transgender women, albeit along with men who have sex with men. Those were the initial clinical trial studies looking at the safety and then the efficacy of PrEP. But currently there are also demonstration projects of actual PrEP implementation around the United States in which transgender women are included. Another way of looking at PrEP is something we call PrEPception, which is essentially thinking about using PrEP as a prophylactic preventive method if planning pregnancy. So in terms of preconception planning, especially in situations where women identify themselves at substantial risk for HIV, including being in serodiscordant relationships where the woman is HIV negative and her partner is HIV positive. PrEPception is another potential use for PrEP in terms of preventing not only HIV to the HIV negative woman, but also preventing HIV transmission to the planned pregnancy. So there's a current, and the only one, I might mention, demonstration project or implementation pilot to examine how PrEP can be delivered effectively in public clinics. It's called the Sustainable Healthcare Implementation PrEP Pilot, or SHIP. It's a new study that was just initiated within the last year and a half. These sites are located in Philadelphia, Chicago, Newark, and Houston. About 1,200 participants will be getting health care and treatment, HIV and STI screening, as well as prenatal care. They'll also be offered PrEP pills and help in using them correctly and in some adherence strategy. To date, about 40% of the people recruited into the SHIP study are women, and that's new because that makes the SHIP study the first study to actually recruit and include women in a demonstration or implementation pilot in the United States to see the real-world use of PrEP in our community. So how would you get PrEP? Well, you have to get a prescription, and there are certain things that you have to have done before that prescription can be issued. First of all, PrEP is only available as PrEP to those who are HIV negative. So you have to have an HIV negative test. There could be no signs or symptoms of a new HIV infection, which means it would also be important that wherever you get your test is that you're also getting the more sensitized test that can detect early or acute new HIV infection. You'll also have to have at least a baseline result of a normal kidney function and normal bone density, and that you're not taking any other medications that might interfere with the drug that's used for PrEP. Also, people who are on PrEP are required or heavily encouraged to get their checkups every 3 months, to include an HIV test and STI screening every 3 months, a pregnancy test, and also following up and checking in for side effects. And there's a really important reason why we say HIV testing and STI screening, and that's because PrEP prevents HIV. It does not prevent other sexually transmitted infections, though it has been shown protective for herpes. It has not shown at all to be protective for other sexually transmitted infections. And so having the routine screening, as well as considering using condoms, even with the use of PrEP, is important for these considerations. PrEP has an out-of-pocket cost that's roughly about $13,000 per year, but in most instances across the country, PrEP is covered by insurance plans, private and public, so that includes Medicaid. There's also a Medicaid assistance program for prescriptions that's provided by Gilead, the pharmaceutical that makes the drug used. That's the only drug right now that's been approved for the use of PrEP in the United States. And there are some state and private groups that help with co-pays and labs because that would be an additional out-of-pocket cost that's not necessarily covered by the medication assistance programs, which specifically pay for the pills or for the prescription. So far, insurance companies and Medicaid programs are covering the cost of Truvada as PrEP, even where there may be some resistance or a few obstacles. In most instances where appeals have been made, PrEP has been covered by those insurance companies. Truvada as PrEP is the first HIV prevention tool that can be fully controlled by a receptive sex partner, which is what makes it such a powerful tool and a powerful opportunity for women to autonomously protect themselves from HIV infection. When talking to your healthcare provider about PrEP, first I would like to say, do not assume that your healthcare provider, if you are visiting a provider outside of the HIV or infectious disease specialties, do not assume that your healthcare provider is immediately informed about PrEP, especially the unique needs of women who may be interested in taking PrEP. So there are tools out there that are designed to help you talk to your doctors about PrEP. The CDC has brochures online and in paper that are readily available. It's very helpful to read before, during, and after a visit when you're interested in talking with your provider about PrEP. Being informed and being assertive to ask for the PrEP that you want, including, even if you have to ask for an HIV test, and in some instances, some women who are listening know this, demand an HIV test from your provider. It's important to be assertive and to not be intimidated, to know the information that you need to know to share with your provider to get the health care that you want and deserve. This particular document here also includes the kinds of questions that you might ask. It provides web resources for PrEP, and you can get it from cdc.gov. There are other PrEP resources online that we will mention at the end. Oh, there they are. So some of the other PrEP resources that are available is there is a telephone hotline for clinicians to call. It also doesn't hurt to have that number available for your own provider just in case they don't have it yet. You can certainly contact us at the U.S. Women in PrEP Working Group through that email address there. There's also a fantastic booklet that is extremely comprehensive, thorough, and fun to read that's been collectively produced with Project Inform and several partners, including Sister Love and the U.S. Women in PrEP Working Group. That can be found at the Project Inform's website in that link that you see here. And there are other websites, including Sister Love's the U.S. Women in PrEP Working Group webpage, PrEPWatch.org, Hive Online, which is a specific sexual and reproductive health line, including lots of preventive information as well as PrEP. My PrEP Experience, which is a blog page of people who are actively using PrEP, and then there's PrEPFacts.org. And this is just a list of citations that you will have in the future for more dedicated referrals for the science behind the use of PrEP. So that's going to end my portion of today's presentation. Again, I want to thank the organizers for today's PrEP4Life webinar, and I look forward to your questions and conversation.
Thank you so much, Dazon, for a great presentation, and thank you to those who have entered questions. We will answer and address your questions at the end of today's webinar series once all of our presenters have had the opportunity to present. So again, we thank Dazon. Our next presenter is Ms. Ophelia Barrios. Ophelia has worked in the area of HIV/AIDS for almost 20 years and is currently employed by Iris House in New York City. She's our Senior Director of Community Health Initiatives, where she is responsible for providing oversight and management of all of the HIV, hepatitis C, sexually transmitted infection, testing, as well as our PrEP and PEP prevention services. She is responsible for shaping and implementing strategic community initiatives that deliver a high level of awareness of those programs, including innovation and impact and creation and developing solid relationships with our community stakeholders. Ms. Barrios has expertise in program planning, prevention education, behavioral interventions, coalition building, strategic planning, and advocacy and policy. She's an active member of the National Latino AIDS Action Network, the New York State HIV Advisory Board, and the Ending the Epidemic New York City Coalition. Ms. Barrios holds a master's degree from the University of New Mexico, a bachelor's degree from Middlebury College. So with that, I will turn it over to Ophelia.
Well, thank you so much, Ingrid, and again, thanks to NWAC and obviously Iris House and Christie's Place for this opportunity to present. So my role here will be to talk about PrEP for women and access to linkage and care to treatment, and in particular looking at the role of community-based organizations and what role they play in ensuring that women have access to PrEP and the work that we do. Okay? So let's get started. Do you see my screen?
Yes, we do.
Okay, good. Well, I can't move it. Hold on. It's not moving to the next slide for some reason.
Click on your PowerPoint button and then just hit your down arrow and see what happens.
No, it's not doing it. Oh, there it goes. Okay, it's slow. So basically, when you're looking at women, ensure that you conduct, especially for those organizations that work to provide HIV prevention services. When women come into your programs, obviously looking at conducting a screening for high-risk behaviors. And those can be based on, if they had unprotected sex within the last, depending on the screening, 30 to 90 days. If they have multiple partners, if they inject, drug use, if they're able to, in some ways or another, disclose those factors as you begin to engage that client into services. And of course, for most of the organizations,
I hate to interrupt you, but we're still seeing your first slide.
Oh, mine pops up.
All right, so I'm going to just take control and I'm going to share from my screen, okay?
Okay.
Okay.
Oh, that was weird. The other one would be as you begin to look at high-risk information, looking at administering an intake and assessment, we will define if the woman is a possible candidate for PrEP. And as she's defining what her risk behaviors are, you begin to have that discussion with her. And based on those risks that she identifies, you offer, the option, for PrEP after you conducted the HIV, STI, or Hep C testing, and especially for those women who obviously disclose those high-risk behaviors. So, for example, one can say, well, if the woman is a monogamous relationship, but indicates that, she only has one sexual partner, but her partner has been unfaithful to her, well, she would still be at high risk because we don't know what her partner has been doing and how many other sexual partners he or she might have. So she would obviously be a good fit as well. The other thing is, once you have that discussion during post-counseling, you provide her as much information as possible. So providing her a fact sheet and information around PrEP and the importance of her knowing as much information as possible. And then offer some time for the client to feel comfortable. If there's additional clarity that she might need in regards to what is PrEP, how should she take it, and so forth and so on. Okay? Next. So at the end, of your session, the woman actually determines if she is interested in being referred to PrEP. If she refuses, for example, says, I'm not ready right now, I have to consider it, I have to really think about it, maybe has to go talk to her partner about this, so you have to give her the option to choose not to get on PrEP. And at this point, you obviously give her as much information as possible in regards to safer sex kits that might include, dental dams, finger cots, male and female condoms, and then you offer as a suggestion to come back, and that should be a routine for all providers. Have her come back 3 months later to retest, even if her HIV test was negative, just in case, depending on her last risk behavior, you still want to re-engage her and have her come back as well. As a provider, if you only provide HIV testing, of course, the recommendation is to provide a referral also for other sexually transmitted infections. And then, of course, providing a list of primary care physicians, especially those that, refer, that, are able to provide PrEP medication to the individual. And when you're making these referrals or that list, think about locations. Sometimes women are, feel more comfortable if their provider is closer to where they live, a geographic area, versus other women because of disclosure issues, maybe still stigma, maybe they don't want to be seen, within their neighborhood. They prefer to go elsewhere. And in addition to that, think about all the other needs the women might have in regards to other supportive services needed. Next. If a woman obviously agrees to get on PrEP, you need to make the appropriate referral to her PCP or the one of her choice, And if possible, I know some organizations already provide escort services to the facility. So in essence, being able to have that, that conversation, and if she commits to going on that day, after her testing, then you should try as best as possible to escort her. One of the items that you should continue to discuss as you talk to her about PrEP is issues around stigma, fear, or phobias, or disclosure issues as it relates to PrEP and high-risk behaviors. This would be an opportunity for you to just open that dialogue between, your client and be able to say, we can hear you, these are some, recommendations that we could offer as regards to this. And even if, for example, the woman, says, I'm definitely interested in getting PrEP, and you escort her and provide her all the information, remember that PrEP is just one of the preventive tools, along with condoms, so ensuring the woman still has, condoms available, and give her that information that even if she's on PrEP, she should always use condoms. And of course, again, the follow-up. You want to ensure that there's a 3-month follow-up if retesting is needed. Next. Provide, linkage and coverage information for PrEP treatment as well, which is very key. I know the previous presenter talked a little bit about it, but one of the issues that we confront often is people want to know, well, how much is this going to cost? Does my medical insurance, pay for that? So having as much information and resources available in regards to private versus public insurance, and also having information about Gilead's copay assistance program, Medicare Part D, and obviously talk to especially those individuals who are underinsured or do not have insurance because of immigration status. Especially if you're working with immigrant communities and you have women who might be at risk but fear not being able to receive this medication because they're undocumented. And also, as we begin to talk about PrEP, similar to the discussions that we had, when we were talking about birth control pills, for example, or even condoms, it's think about the risk associated with this. Is it safe enough for a woman to take, PrEP? Think about issues of, intimate partner violence. What can happen to her if she discloses to her partner that she's now decided to get on PrEP? Would she be accused of having, of cheating or being unfaithful to her partner? Think about post-traumatic stress disorder, mental health issues. What are issues that the woman is confronting alongside with potentially being at risk for HIV infection, but thinking of other, comorbidities or social determinants of health, including drug use, alcohol use, talking about harm reduction. Also think about what is her housing, living situation, and economic factors. If she gets on PrEP, does she have a stable home where she lives and she can keep her medication there? Does she have a place to store them if she's living in in a shelter, for example? What if she cannot pay for that, the co-payment, through her insurance if she has insurance? How can we ensure that she has enough, financial security to be able to purchase the medication as well? And then, of course, the referral, but also follow-up, which is very important when you're talking about PrEP treatment. So when the woman is finally, escorted, and there's also, a follow-up with her PCP, make sure that you're there. So the woman, is okay with you going with her to her appointment. Ensure that there's, there's a follow-up appointment. Make sure that you stay with her until she is seen by her PCP, and that there's a conversation between her and her PCP about what follow-up appointment she needs to make. How does she schedule, how is she going to receive her medication? What other medications she's taking, for example, that might, have some side effects, to what, to PrEP medication as well. And then also ensure again, that, the benefits to PrEP, and as well as ensuring that there's further assessments if needed, depending on side effects and, her needs as well. Next. And then, of course, when you're looking at, basically conducting a follow-up, determine, if the accurate, if the woman received the accurate information from the PCP, and if appointments were made, and if the actual PrEP medication was prescribed to her. Ensuring that the pharmaceutical company, for example, or the, pharmacy where she's getting her medication, that is able, to fill her prescriptions, And also, as you begin these conversations, making sure that you use motivational interviewing, reinforce the need and the benefits for her to adhere to her PrEP medication. So think about, talking with her about the long-term usage, and even if there's side effects, for her to disclose those to you, and so that you're able to at least provide her some coaching as to how she can go back to her PCP and have these conversations with him or her. Also, discuss the use of condoms along with PrEP to reduce other STI infections. Just because we're reducing the HIV transmission by taking PrEP, that doesn't always, mean that she might not be at risk for other STIs. This also includes ensuring that she gets tested, if she has had unprotected sex, ensuring that she knows about other sexually transmitted infections, and there's risks that, you know, she might be placing herself as well. And of course, discuss the need to follow up with the PCP about the lack of usage or side effects. You know, maybe she decides to, you know, get off the medication, but she has not disclosed this to her medical provider and feels like, I don't know how to talk to my medical provider. I don't know, you know, how he or she might view me now that, you know, I went this far to get on PrEP and I've decided not to use it. But these are conversations that we should continue to have as we do a follow-up with the woman. Next. So I want to thank everyone for being a part of this webinar series. Here's my contact information in case you should need additional information, especially for those who are participating in New York City area.
Thank you so much, Cecilia. So our next presenter that we're excited to have join us today, we wanted to make sure that we not only gave kind of the clinical and community-based provider perspective on women in PrEP, but we also wanted to actually hear from the voice of a woman who has gone through an experience talking to a medical provider and talking to others about using PrEP. So today we're very excited to have Prue Mendiola. I realize now, I think, Prue, that we may have your name spelt wrong here. So Mendiola. Prue has been working in HIV prevention with at-risk populations for the past 5 years. In that time, she has served in a number of roles, including HIV counselor and tester, group individual level interventionist, research assistant, and process evaluator. She currently works as a project evaluator for the Alexis project and as a research assistant with the Transnet Tech Study at Friends Community Center, which is a branch of Friends Research Institute. Through her work, she hopes to touch as many lives as possible, helping people reach their personal goals, lowering their risk for HIV acquisition or transmission, and helping HIV-positive individuals become medically adherent and live happy and healthy lives. So with that, we want to present Ms. Prue Mendiola.
Thank you. Good morning or afternoon, everyone. So to be honest, I do a lot better with question and answer portions, but I just thought I might provide a little bit of, you know, the first-hand perspective as well as the provider perspective, and sort of just go through my story of how I decided to get on PrEP. And mainly the first reason I did so was to experience it for not just my sake, but my clients' sake and the communities that I serve. At the time when I was making this decision, I was and still am serving on a community advisory board for PEP and PrEP programs in Los Angeles County. And the perspective that I was providing there was as the chair of the Transgender Service Providers Network. So they really wanted to get the perspective of transgender women in Los Angeles County to see how best we could be rolling out these projects. And a lot of the times we would be going through and putting together panels to educate communities on PEP and PrEP. And one of the hardest things we had to do was find transgender women who were on PrEP. So at one meeting, I sort of jokingly said that, well, perhaps I should start PrEP just, you know, so that we could have a panelist whenever we decide to do this. And then after that, I sort of started to take that seriously and just sat and thought about my own risk and exactly why that would or wouldn't be a good idea for me. So I began thinking about it, and I began speaking to, you know, friends and colleagues, sort of deciding if that was something that I wanted to do, which at that point I had already decided it would be great for my community to be able to provide that perspective, and it would be great for the work that I was doing. However, what I hadn't decided yet was whether or not this would be a good personal option for me. At the time, I was married in a long-term relationship, monogamous, and at that point we were not using condoms anymore. So I began to think, okay, well, although we get tested, although we are monogamous, there's still always that risk, and statistically speaking, transgender women are most often infected through their main partners, thinking that they're monogamous when in fact, you know, the partner does go out and be unfaithful and then, you know, bring something home, unfortunately. So I began to think, yes, I trust my partner, but at the end of the day, better safe than sorry, and this would be a great tool to have under my belt. So I called up my doctor one day, and I'm fortunate enough to have a wonderful doctor who is also an infectious disease and HIV specialist, which is another great story. But I'm very blessed to have Dr. April Soto from Kaiser as my primary care provider, and she does a lot of work with transgender women and with people who are HIV positive. So I spoke to her and I said, you know what, I was kind of curious as to what you think of me starting PrEP. And she said, well, PrEP, prevention, Truvada as prevention for HIV. And I said, yes. And she said, okay, why not? Well, we'll come in, we'll meet about it, we'll discuss it, and then we'll just have to run a few tests and get you started on that right away. So I said, great. The actual process of starting that was actually a little bit more complicated, and that was even after the fact that I had far less barriers and obstacles as many people do. I have great medical coverage, I don't pay a dime for anything out of pocket, and a wonderful doctor, a wonderful provider, but they still had me jump through several hoops. Lots of testing, some tests took a week or two to come back, answering questions, being interviewed. I had to see 2 different people, then go get lab work done. And the whole process took about a month and a half. My concern with that is, although I know that medically speaking, you would want to make sure you're not giving PrEP to somebody who's already HIV positive for the chance of them becoming resistant to Truvada or other drugs. And also interactions with other things, with hormones, which actually, also speaking to that, there's little to no reaction as far as hormones go in my experience. However, I want to talk a little bit about seasons of risk and the fact that statistically speaking, when somebody is seeking out PrEP, it's because they are putting themselves at a significant amount of risk that would be concerning enough to them that they would want to take PrEP as an option. So at the time, I had felt that there was that risk and it was something I wanted to do, and also I was going through a separation later on during this process, which was interesting, and I was at this point where I felt like I was going to start dating, I was going to start experiencing other men, and due to that, I wanted to have every method of prevention at my disposal. So it did take about, as I said, a month and a half to actually start on the PrEP, and once I did, it was a lot easier. It was just about routine testing, picking up my prescription. I could have it delivered if I wanted to, so it became a lot easier. But going in every 3 months or more often than that to be interviewed by someone, to get a check-in, to run tests, to wait a week for them to come back, it began to become very tedious. I did it because at the end of the day, it was something that I wanted to do that I felt was working for me. The only side effect I experienced was a little bit of weight loss, which I did not complain about. But other than that, the whole process, as far as taking the PrEP, was pretty easy. Another concern that we like to think about when we think of experience with people and taking any kind of medication is, are they going to be adherent to it? As we know, PrEP is about 98% effective when taken properly, and that's about 4 pills a week. And I myself, although I'm good at taking prescriptions as prescribed, did miss a dose or 2. But, for the most part, I was regularly adherent. Other than that, the entire process was relatively simple. The only other concern that I had was actually being able to speak to people about it. I faced a lot of stigma. People are very traditional when it comes to prevention, and they want to talk about condoms as prevention a lot of the time, and sort of dismiss you if you're saying you want to take PrEP as an option. And I remember a lot of the questions that I were getting were very sort of insulting. And also I felt that my personal sex life was my business, and what I did in my bedroom was none of anybody's business unless I decided to share it. So that was pretty much the experience. At this point, I am I am off the PrEP at the moment because I haven't been able to go pick it up. So again, that does become a problem when you have to go in constantly and your life sort of gets in the way. But I am starting up again. I've already set up an appointment to go and get that done. That's pretty much my story. And, you know, if there's any questions or comments, I'd be happy to respond to those. But I think that's most of what I have to say.
Thank you so much, Prue, for sharing your personal story with the group. We have several questions that have come up through the question panel. So I'm going to start with those questions, and then there are some people who've had their hands up for a while, and I'm not sure if that's by accident or not. So I'm going to start with the people who've entered questions in our question pane. If you have questions, you can enter them that way, or you can raise your hand, and I'm going to hopefully have enough time to get through all of our questions. So our first question is for Dazon. This was from Estella. She asked a question regarding the demonstration project. Will there be an evaluation of the study that will inform other states and communities about the outcomes of the study? How is the service funded, and is there a potential for public funding for the larger high-risk negative population in other parts of the U.S.?
Excellent, excellent questions, and I'm going to start with the last one first. Currently, to my knowledge, there is no public funding specific to provision of the direct PrEP services, other than through the current means that public resources are used, like through the Affordable Care Act. So if people are enrolled in the Affordable Care Act, if they happen to be in states or jurisdictions, unlike most of us here in the South, if they happen to be in states or jurisdictions where Medicaid has been expanded, then there is funding or coverage for PrEP through those means. But in terms of PrEP as a direct service, there's some public funding in the way of PrEP education and PrEP delivery, though it does not pay for the actual prescriptions in public health settings, and that's through some of the CDC funding that goes to health departments both at the state and at city levels, like in the latest round of the HIV high impact prevention funding includes some funding for PrEP, and for some sites start up PrEP services while it doesn't pay for the meds. The demonstration project itself is, and while I cannot profess to know the entire protocol in terms of the plan, it is exactly just that, the implementation pilot of implementing PrEP in at least 2 family planning settings and 2 STD clinical settings is meant to tell us more information about how the real world use, especially with women, transgender women and urban folk, especially African American and Latino populations, are accessing, adhering to, and responding to PrEP, and how that's impacting the incidence levels of the incidence rates in those jurisdictions. How that information is going to be distributed, it's a CDC project that's actually funded through the CDC Foundation by Gilead funding. So even the funding for this CDC initiative is not publicly funded. So I think that there's much more work in terms of advocacy to be done to ensure that ongoing implementation strategies support public funding. Where there are high-impact funds, that PrEP funds are included, that women's PrEP services are included at least equitable levels of resources so that they can have access in their communities.
Thank you, Dazon. I have another question from Stella. She said, questions regarding insurance coverage for cost of PrEP. If covered by Medicaid, does this include managed Medicaid plans or just straight Medicaid?
So I wish I knew the answer to that question in terms of the distinction between managed Medicaid programs versus straight Medicaid. I'm wondering if Ophelia has an answer for that.
And
my understanding is that Medicaid Part D can cover some of the cost as well, but it's based on the insurance that the individual has. So some can cover more than others. That's as far as I know. So it's based on the insurance type.
and it also would be based on what state you're in, because each state
Right.
Medicaid plans have different things that they're covering. A lot of states, for instance, New York State is one that has advocated to have PrEP as a part of its of a part of the plans and what the plans will cover. But it is state by state and what each state's Medicaid and managed care plans will cover. So the answer kind of differs depending on what state you're in.
Absolutely. At the federal level, there are no restrictions through the CMMS or the Center for Medicaid and Medicare Services. There are no restrictions through the CMS program for PrEP coverage through public funding. And in addition to the resources that Ingrid and Ophelia just talked about, in some states, it's a small number of states, but in some states that have actually ramped up their prevention efforts to also put some significant investment into PrEP coverage, there are programs that are PrEP drug assistance programs that are in some ways very similar to the AIDS drug assistance programs that are available through Ryan White for people living with HIV. So it would be helpful to know that if your state has implemented that program or not, and that would be obviously available through your own health department.
Okay. Our next question asks, is there any information indicating Black women's receptivity to considering PrEP as a preventative measure?
There are some qualitative studies that, although they're very limited in terms of number and in terms of extent, this is the purpose of having the demonstration project running. There are some programs that have just been recently funded in the past year to do just that, so I imagine we won't see real data coming out of those programs for another year. But I can tell you anecdotally that we haven't seen the level of numbers of uptake, even in African American women, to really get a full handle on being able to generalize the experiences there. So we're still in the early stages, and I think that's important for us to remember that, we're 3 years, almost 4 years into PrEP's approval in the United States, and given the fact that there's been not a robust effort to reach women with this information and education, by and large, most women are still not even aware that PrEP is something that's available to them. And so we have a long way to go to continue to educate our community so that women are asking, when they determine their levels of risk for HIV infection, that they're able to ask for or demand and receive the level of PrEP services and care that they need, so that we can answer some of these questions around the attitude. What we do know is that for women who are taking or have taken PrEP, it has, and this would have been a question I have for Prue, it has tended to be inside decisions around preconception in terms of planning for a pregnancy, especially if they know that they are at substantial risk through whether it's multiple partners, through its commercial sex work, through it's just not knowing partner status or not using condoms as a part of protected sex. And so in addition to preconception, there's the fact that for women who are aware that they're in serodiscordant relationships, that this is an option for them. And what I will say is for some of the women that I've had a chance to talk with, and these have actually been women who are in sub-Saharan Africa who are participating in or are on PrEP, one of the largest responses that comes from them is that whether their partner is positive or they're in a serodiscordancy, that the power of PrEP in their hands to protect themselves without having to negotiate with anyone else, despite some of the burdens and some of the, as Prue described, the back and forth the power of the prevention in their own hands is worth some of the extra that they have to put in to be on PrEP.
Okay, so I'm going to go to a couple of the people who have their hands up, and then I'll come back to the list of questions. So the first person is Addie Shore. I'm going to unmute your line. However, it tells me, Addie, that you can't be unmuted until you enter your PIN number. So if you could enter your PIN, then I'm going to come back to you. All right, Nelsie, I'm going to unmute your line. Nelsie Calamino, you're unmuted. All right, we'll come back to Nelsie. Deborah Mitchell, you're unmuted. Although I have you unmuted, you may have your phone lines unmuted. You may have your phone itself on mute. So I'm going to come back to Deborah. Nicole Gibson.
I think you and I already started to do that before, but you can check them, see, because it has the tag on it that says closed. I think we did that already, but not.
Okay, we'll come back. I don't think Nicole is talking to us. Derek Wallace, you're next. Again, if people on the phone, if you have your hand up but you have us muted, when I unmute your line, we're still going to be muted. Derek? All right. Ruth Velasquez. All right, we'll come back to the people on the phone. I think some people may have just had their hands up by accident, so we'll go back to our questions. Julie Patterson wanted us to know that Project Inform just created a trans-specific PrEP booklet as well. So as another resource for people, Project Inform has a trans-specific PrEP booklet. Kelly Brevard asked, is it possible to have this slideshow presentation emailed to us? And I'm glad you asked that. You and probably 5 other people have asked me that. The slides are going to be available on the Iris House and the NWAC and Christie's Place websites after we finish the next session in cycle 1, as well as once you have completed your evaluation, then you will have access to see and view the slide materials from today. And again, we just want to thank Gilead for making this webinar possible for us and allowing us to be able to share this information with you and being a supporter of our PrEP4Life initiative.
And Ingrid, if I may, this is Davon again. For the portion on the PrEP 101 that I gave, that is actually a prepared, and we use the word canned, presentation that also comes with a very simple, brief PrEP facilitative outline that will be available through our webpage as well as through the U.S. Women in PrEP Working Group Facebook pages. It should be today, but it will be within the next couple of days. So by the end of the week, that presentation, along with notations for each one of those slides and a PrEP guide, facilitator's guide, will be available for anyone to use in their own education purposes.
And Dazon, if you could share that link with us once it's up, and we'll make sure that people who participated get that as well.
Absolutely.
Amelia asked, what does candidate mean? Should all women be candidates, or do we need for them to disclose high-risk behaviors first? So I'll leave that for any of the 3 panelists. Prue, do you want to start with that one, and then Ophelia?
Sure.
I'm sorry, can you repeat the question, please?
So she's asking, should all women be considered candidates for PrEP, or do we need for them to disclose high-risk behaviors first?
Well, I personally believe on that note, if anyone feels that PrEP would be a good option for them, that automatically makes them a candidate. A lot of the times, like I spoke of, there's seasons of risk, and if somebody is considering PrEP, then there has to be some level of risk behind that. It's relatively safe for the most part, so I don't feel that anyone should be necessarily disqualified. The only people who should be are occasionally there's some instances with bone marrow loss, so those with osteoporosis might have some trouble with it, also people with kidney problems, but for the most part it's an extremely safe medication, and I think it's a very viable option for anyone considering it.
Ophelia, do you want to chime in?
I agree with that, and also And when I use the term candidate, that's because when we are screening individuals, typically when they fill out the paperwork, they often don't disclose, any risk behaviors. And once you start talking with them and then they open up, they're able to disclose that they in fact have either multiple partners, or they engage in IV drug use, or they're sex workers, or their sexual partner has multiple partners. So I think in that sense, that's where you have to build on that trust so that she feels comfortable enough to disclose whatever her personal risk factors can be, and also that those of her sexual partner or partners. And through that, be able to say, hey, like I said, the example I shared was that woman that is in a quote-unquote monogamous relationship, but yet her partner has another sexual partner. So she might not be the one engaging in the risk behaviors, but it can be her sexual partner that's placing her.
I'm sorry, Ophelia. I think I accidentally muted your phone. Hold on one second. And I can't unmute you until you enter your PIN as well. Somehow I accidentally just muted you in the middle of what you were saying. Okay.
So, well, Ingrid and Davon was muted too. I'm glad to be back. I would also add that some of the tools that are available can help women specifically walk through. The CDC itself has a set of guidelines that clinicians and providers are guided to use in terms of helping screen folks. Because I absolutely agree that if a woman determines for whatever reason that she believes that taking a pill, that she is at the level of concern for HIV infection enough that she believes taking a pill per day to prevent infection is what she needs in her life in that moment, or for however long she believes she needs it, then she should have access to that. There are considerations, however, in terms of how we specifically give priority to people who may actually be at substantial risk. And I give the example, and it doesn't have to be specifically in terms of behavior, but it can also just be a combination of behavior in an area, a community where the HIV infection rates or the HIV incidence is actually very high, which increases any person's chance of getting HIV if they're having sex that's not protected one way or another. If there are some of those circumstances that we've mentioned already in different relationships where one person is positive and the other one is negative. And by the way, just for giving more confidence to the efficacy of these medications, the Partners PrEP study, which was the signature study between male and female couples, or men and women, that ran a second demonstration project over the last couple of years, and determined that in serodiscordant relationships where the positive person was adherent to their medications and virally suppressed, and where the HIV negative partner was adherent and took their PrEP every day, there was zero, absolutely no transmissions inside those relationships. And so I think it's appropriate for anyone who says, in this moment, in this time in my life, I believe that I am at greater risk than maybe at other times, and I would like to have extra protection. And again, when Prue talks about seasons of risk, I think it's important to think about what those seasons might look like. There are seasons around planning pregnancy. There are seasons around the types of sexual activity and sexual relationships or intimate partners, numbers, as well as activities that we may engage in. I know of an instance where a young man knew that he was going away on an extended internship overseas, and decided that PrEP was going to be the best strategy for him for protecting himself from HIV, even though when he returned he knew he had reduced his risk because he had one partner at home. So there are different seasons and different moments where people they feel that they are at more substantial risk. I try not to use the word high anymore because high indicates a specific level that you may have to achieve in order to be determined or decided by someone else whether you should be a good candidate or not. I think if you determine what your baseline of risk is and what's substantially more for yourself, that should be the level of risk that you determine whether you want to be on PrEP or not.
All right, thank you. I think that leads into our next question that we had, which was, is PrEP similar to HAART in that you risk building resistance if taken inconsistently? And I think everything that we've heard from Gilead and from all the studies is that if you are not HIV positive, you will not build up resistance through taking PrEP inconsistently. However, you do put yourself at risk of becoming HIV infected if you are still participating in sexual behaviors that you're not using other sources of protection. So from everything that we've heard, there's no resistance if you're not HIV positive to taking it inconsistently. However, you do put yourself at greater risk for HIV infection if you're not using other forms of protection.
And it is also the key reason why folks who are on PrEP are asked to get screened for HIV every 3 months so that you can detect it early enough so that if there is a seroconversion for whatever reason, that you have not built up resistance if Truvada needs to be a part of your regimen for your HIV treatment and care.
Okay, we only have a few more minutes. I'm going to go to one of the hands. So Nelsie, I'm going to try, your hand is still up, so I'm going to try unmuting you again. Nelsie, are you ready? Okay, Nicole Gibson, are you ready? Okay. Derek Wallace, your hand is still up, but I can't unmute you, so I'm going to go to the question that you entered. And your question was, when it comes to a couple trying to get pregnant, does the viral load on the male have to be low? And just for clarity, is the mother able to breastfeed? So I guess for clarity, Derek, in your question, in this couple, is one person HIV positive and the other is not? Is that what we are assuming? If you could just type that in for clarity, and then we'll come back to make sure we answer your question. All right, our next question. Which study or studies have shown that PrEP may reduce or prevents the contraception of herpes?
So I can take that on. There is the initial proof of concept study of the topical version of PrEP in the Christie 004 study, which was the first proof of concept that PrEP was working, that came out in 2010. And a key additional finding to that study, it was a smaller study of about 900 women in South Africa particularly, that showed a level of efficacy in the tenofovir gel at that time, showed that there was a 50% reduction in herpes transmission, along with the reduction in HIV transmission for those who were adherent to using the gel on a consistent basis. That being the only trial so far where we know that there's been a reduction, but some of those larger studies that we talked about that are still in demonstration phases are also collecting that data, and we should be hearing about that. I should let folks know that it's important to stay tuned. The Conference on Retroviruses and Opportunistic Infections, also known as CROI, which is usually our biggest pathogenesis meeting, which presents a lot of the latest science, will be taking place in Boston at the end of next month. And so there may be new data coming out to answer some of these questions because the science is moving so rapidly. And I say that because that also includes that there's a possibility that we'll be hearing the results of a trial that's been going on for the last 5 years to look at the efficacy of using antiretrovirals in a ring similar to the NuvaRing or the contraceptive ring. This particular study was called Aspire, and we're looking to hear early this year, hopefully by that time, from the ASPIRE study on whether or not they found efficacy in that delivery system as well.
Okay, we have a few more questions. I'm going to try to make this fast. And our panelists, if you could just give some short, succinct answers to these, that'll help us try to get through everyone. We have about 4 minutes, and I still have some housekeeping that I have to do. Stephen Manigault raised a great question. However, I'm not going to read all of it due to time, but basically he's saying there are a lot of people who are in prisons and in the prison population where we know that there are higher rates of HIV and STIs. And is there any work or advocacy happening for men and women inside our prisons regarding PrEP and PrEP access? Do any of our panelists know of any currently?
At a very low level, there's some advocacy, but it is it's a very, very difficult issue to tackle because people would have to acknowledge and support sexual activity in prisons and jails at the first place.
Right, and I think it's the same struggle we have with trying to have condoms available in prison.
Exactly.
Yeah.
All right, our other one is from Antonetta Etienne. Is there or will there be any studies regarding lesbians and bisexual women in PrEP?
As far as I know, I have not read or heard that there will be. I think there were women involved in some of the original studies, but as far as I know, not now. And maybe this is a discussion we should have based on the fact that some of the work that we have done here at Iris House, when we've talked with women who self-identify as lesbian or bisexual, some actually disclose that they still continue to have sex with their male partners. So when you look at the rates of infection among lesbians in particular, who only have sex with other women, obviously the risks tend to be lower. But it's more with bisexual women who engage in risk with heterosexual, with males, then that's a discussion we should have in regards to ensuring that those women, regardless of their sexual orientation, do get access to PrEP and are also part of the discussion that we have to ensure that all women, regardless of their sexual orientation, are prescribed PrEP if they feel that they should be taking it.
All right, I'm going to
I agree. The only thing I would add, Ingrid, is that, of course, of the 4 sites where the SHIP study is being implemented, it is certainly not exclusive and does not include women who have sex with women as well.
Okay, great. So Derek's question, he added some clarity. So his question was, in a relationship where the male is HIV positive and the female is negative, if the female chose to be on PrEP, would she be able to breastfeed? And I would say, and that, Derek, may be also a great question for our panel next week, where we have Dr. Teresa Mack, who's going to be on and talking about the medical provider side of it. And that would also be a great question for her. But I don't know if any of our panelists today want to tackle that one.
If she's negative, there's no risk of transmission, and breastfeeding would be safe.
Okay. Our Jorge Benitez wanted us to include that although microbicide and the Caprisa had efficacy in preventing herpes, tenofovir is only one part of the Truvada medication. Truvada also has a medication called, and I'm going to screw this up, but intricitabine. I can't even pronounce this.
Intricitabine.
Thank you.
Uh-huh.
And he says Caprisa only had 1% tenofovir. All right, I know we weren't able to get through everyone's questions, but I just want to, again, because we're out of time, want to thank everyone for participating in today's presentation. I do have just a few housekeeping tips, so if you could just entertain me for another minute. You are going to receive a link at the end of this webinar that will allow you to complete a post-webinar survey. We're asking that everybody please take a few minutes and complete the post-webinar survey. That will help us determine the effectiveness of this webinar and what changes we need to make. As we indicated, we will be repeating this particular session in the fall. We also will have another cycle after we finish this one that's going to be targeted to young men. So we hope that you will also register for that one. In addition, for the National Women and AIDS Collective, we hope that you will consider joining and becoming a part. We have a general membership that is for organizations of any size, an associate membership for individuals whose organizations may or may not want to join, or if you individually want to support NWAC. And we ask that you visit our website for more information, or you email any of us to get information on NWAC and the benefits of joining the National Women in AIDS Collective. So again, as from Iris House, Christie's Place, the National Women in AIDS Collective, and our PrEP4Life project, we thank all of you for participating today. We will send out a link to everyone who participated once the slides are available. Again, they will not be posted until we finish next week's sessions and we make any final edits that we need to with notes, and we will have those available for you. So as long as you attended today, you will receive an email from us as a follow-up. I really want to thank our presenters, Dazan, Ophelia, and Prue, who provided a wealth of information. Just so the presenters know, there were a lot of people who said a lot of thank yous through the question panel. They thought the information was very well presented and helped to clarify a lot of the myths and information that they may not have known, so they can now present it in a more effective way. So we thank all of our presenters, and again, we thank you for participating with us, and we look forward to you all participating next Tuesday, same time, same place. Thank you.